Nerves. Published by WordPress.com. Peripheral nerve injury in the wrist and hand. Anatomy and functional structure of peripheral nerves. Nerve sheath surrounds the entire peripheral nerve. Epineurium surrounds a group of fascicles within the peripheral nerve. Perineurium surrounds individual fascicles. Endoneurium surrounds axons and forms tubes. Fascicles, groups of axons. Myelin sheath surrounds single axon, formed by Schwann cells, increasing conduction velocity. Neuron structure. Body, metabolic center of the neuron. Axon carries electrical signals away from the cell body. Dendrites receive input from other cells. Types of nerve fibers. A fibers, 10 to 20 micrometers, heavy, fast conduction, responsible for touch and automatic functions. B fibers, less than 3 micrometers, moderate, medium speed conduction, involved in non-touch sensations like pain. Blood supply. Extrinsic vessels, located in the loose connective tissue surrounding the nerve trunk. Intrinsic vessels, plexus in the epineurium, perineurium, and endoneurium. Pathophysiology of nerve injury. Mechanisms of injury. Closed injury, caused by stretch, traction, compression, local ischemia, increased permeability, or microcirculation damage. Open injury, sharp clean injuries, crushing, gunshot, radiation neuropathy, and entrapment neuropathy. Degeneration types. Axonal degeneration, damage to the axon and myelin sheath. Wallerian degeneration, affects the distal fragment of the axon and the node of Ranvier. Nissl granules disintegration, breakdown of cellular machinery. Myelin sheath breakdown, into droplets, which are later removed by macrophages. Regeneration. Schwann cells proliferate, forming new tubes, and axons grow towards the distal fragment at a rate of 1 mm per day. Factors affecting prognosis. Age and general condition. Younger individuals generally recover better. Nerve type. Radial nerve injury has a better prognosis. Level of injury. Distal injuries tend to have a better recovery rate. Repair delay. Delays beyond 18 months reduce the likelihood of recovery. Mode of injury. Sharp injuries generally have better outcomes than crush injuries. Classification of nerve injuries. Set-in classification. Neuropraxia. Focal demyelination, complete conduction block, reversible, no Wallerian degeneration. Axonotmesis. Axon and myelin damage, but endoneurium remains intact, reversible with recovery of axons and muscle function. Neurotmesis. Complete nerve disruption, irreversible injury with no potential for recovery. Sunderland classification. Neuropraxia. Preservation of all nerve elements except myelin. Axonotmesis. Disruption of axon and endoneurium, but perineurium and epineurium remain intact. Neurotmesis. Complete disruption of the nerve including endoneurium, perineurium, and epineurium. Clinical presentation, C.P. History of injury. Causes may include labor-related trauma or other direct injuries. Motor symptoms, weakness and wasting of muscles. Sensory symptoms, paresthesia, pain, and loss of sensation. Deformity. Visible structural changes like claw hand or dropped wrist. Trophic changes. Thin, dry, shiny skin, brittle nails. Reflexes. Loss of reflexes in affected areas. Investigations. X-ray. To rule out associated fractures. Ultrasound or MRI. NCV, nerve conduction velocity, and EMG, electromyography, to assess the severity and level of injury. Treatment. Conservative management. Indications. First-line treatment for less severe injuries. Methods include splinting to prevent overstretching of muscles, physiotherapy, and galvanic stimulation to prevent muscle wasting. Operative management. Indications for early nerve exploration. Open injury, associated vascular injury, and iatrogenic injuries. Indications for late nerve exploration. Failure of conservative treatment or injuries in the plateau phase. Nerve repair. Neurolysis. Mobilization of the nerve to relieve constriction. Epineural repair. Direct repair of the epineurium. Interfascicular repair, used for nerves like the median and ulnar nerve in the distal forearm. Neurotization, nerve transfer, transfer of working motor nerves to those that have lost function. Reconstruction. Tendon transfer, used when nerve regeneration is not possible due to distance from the injury site to muscle. Gracilis muscle transfer, the most common free muscle transfer for severe injuries. Arthrodesis and osteotomy, surgical options for joint stabilization.